Thank you, Vanshi, and thank you, Diabetes India, for the opportunity. My talk for today's discussion is heart failure with preserved ejection fraction in diabetes. What are the clinical challenges we face day in and day out? Clinical challenges, I have put 10 in number. One being silent cardiac tsunami. HFpEF represents 50% of all heart failure cases. That is very, very important, and that is why I call it tsunami. It is due to aging, obesity, and diabetes that the incidence is increasing. Of all HFpEF in diabetes, the diabetes is present. All of HFpEF patients, diabetes is present in around 40 to 45% of cases. It is a major accelerator of cardiac stiffness and fibrosis. It is because of obesity and insulin resistance that HFpEF is more common in diabetic than HFrEF. HFpEF has morbidity and mortality comparable to HFrEF. Very important statement. It is not a benign condition as we often think. Most cases are diagnosed late, often at time of first hospitalization. Diabetologists are uniquely positioned to diagnose HFpEF early. That is, the onus lies on us. Now, how do we diagnose HFpEF? HFpEF is by a mnemonic PEF, P-E-F-F. That is what it is seen. Pre-test assessment is PEF, the P of PEF. It consists of symptoms, comorbidities, ECGs, echo, natriuretic peptide and ergometry, and 6 minutes walk test. Diagnostic workup is step 2, that is echocardiography and natriuretic peptide score. Then comes F1, the advanced workup, functional testing in case of uncertainty. And then comes F2, the etiological workup that includes final etiology. So coming to diagnosis of HFpEF, symptoms and signs, LVEF more than 50% is the diagnostic of HFpEF. Cardiac structural abnormalities should be there. There should be functional abnormalities. Echo, which is transthoracic, must show EA ratio, TR velocity, and PA systolic pressure, which is abnormal. Congestion and BNP and anti-BroBNP levels may be raised. Echocardiographic criteria, that is non-invasive HFpEF diagnosis, comes with 3 out of 4 echo criteria: decreased septal tissue Doppler velocity, elevated left atrial volume, average mitral inflow or tissue Doppler velocity, tricuspid regurgitation velocity of more than 2.8 meters per second. Clinical suspicion is the third major thing. It comes with score, HFpEF score, that is sum of 0 to 9. H2 PEF is the mnemonic, that is what it has got points 2, 1, 3, 1, 1, 1. Fourth is the clinical dilemma is heart failure in type 2 diabetes. What is HFpEF versus HFrEF? And this comes from Diabetology, Cardiovascular, 2025. It shows that HFpEF is more common in elderly, female, obese, metabolically undiagnosed, limited use of GDMT, guideline-directed medical therapy is there, while HFrEF is more common in younger, male diabetics. IHD and arrhythmia are more common and more often diagnosed with GDMT. Now coming to pathophysiology of HFpEF in diabetes, it is because of endothelial functional injury. These changes occur. There is abnormal fatty acid metabolism. These changes occur. There is dysregulation of glucose metabolism, and that leads to HFpEF, and that is very, very important to understand that all these happen in diabetic individuals. Now, sixth clinical dilemma is with time there is progression of HFpEF. It begins with maybe exercise-induced LA hypertension. Then there comes resting LA hypertension, and then comes right heart failure. So it progresses from HFpEF to HFrEF. Seventh dilemma is why HFpEF in diabetes is frequently missed. Because of non-specific symptoms, misleading biomarkers, requires high index of suspicion, which we as diabetologists frequently miss. Preserved ejection fraction should be there by definition. Normal resting hemodynamics in most of the patient. No single gold standard non-invasive test is there to diagnose. Diabetes itself causes metabolic toxicity, microvascular disease, and inflammation. Diabetes worsens autonomic dysfunction and renal sodium retention. Number 8 dilemma is when to suspect HFpEF in diabetes. These are the patients with unexplained exertional dyspnea or unexplained exertional fatigue. There is recurrent edema. Many times we miss these patients. Weight fluctuations are there. History of obesity, I already told you. Hypertension, atrial fibrillation, and CKD. Echo shows LVH or LA enlargement. Normal BNP does not exclude diagnosis of HFpEF. Now coming to treatment, it is by use of SGLT2 inhibitors, loop diuretics when indicated, ARNI when indicated. GLP-1 RA and finerenone have changed the treatment, and there should be treatment of comorbidities. Guideline directed medical therapy in HFpEF in diabetes includes SGLT2 inhibitor are the first line treatment in majority of cases, maybe loop diuretic if indicated. MRA are important in certain group of patients. RNA are required in certain group of patients, and ARB may be those who cannot afford or tolerate RNA. Their ARB can be used. So final take home message is, what should a diabetologist do? Think HFpEF in symptomatic diabetic patients. If there is exertional dyspnea, if there is exertional fatigue, think of it. Use SGLT2 inhibitor proactively. Don't stop SGLT2 inhibitor in elderly because they may be the harm may be done in these patients. Aggressive target of obesity and aggressive treatment of hypertension. Do not rely solely on anti-proBNP or ejection fraction in majority of cases. Use your clinical acumen. Collaborate early with cardiologist whenever in doubt. HFpEF is a dominant heart failure, not a non-dominant heart failure, then HFrEF in diabetes. Pathophysiology of HFpEF is systemic and is metabolic. SGLT2 inhibitor and GLP-1RA have changed the landscape of treatment. Early detection is the real cure. Thank you very much.